This talk is about easily missed musculoskeletal injuries. The radiographic findings of certain musculoskeletal injuries can be subtle. Small avulsion fragments or minimal malalignment may not be appreciated, and missing such injuries may result in chronic and debilitating sequelae for patients. Injuries are more likely missed in the setting of polytrauma and distracting overlying hardware. Knowledge of these pitfalls will alert radiologists to pay special attention to the common appearances of these injuries in their routine search patterns. In a study by Petineau, there were 1954 false negative musculoskeletal readings out of a total of 152,000 emergency department radiographs. In this study, acute fractures accounted for the largest number of false negative studies, and the vast majority of the misses included fingers, rib, and toe fractures. In a study by Gooley, 80% of diagnostic errors in an emergency department were missed fractures, and 78% of these were due to misinterpreting radiographs. Here, again, we see that fractures were the vast majority of misses. Other things that were missed included dislocations, tendon and nerve injuries, ligament injuries, and foreign bodies. The most common reason for the miss was that the abnormality was missed on the radiograph. Other problems were failure to take the radiograph, the wrong radiograph was taken, and clinical error. In a study by Kachalia, fractures were the leading cause of malpractice claims due to missed or delayed diagnoses in the emergency department. In a study by Brooks, 75% of all missed injuries in 45 major trauma patients were musculoskeletal in nature. This shows the missed fractures in their study. In a review of the literature by Stănescu, titled Diagnostic Errors in Polytrauma, a structured review of the recent literature, they found that injuries were missed 15% of the time during the primary survey, 25% of the time during the secondary survey, 15% during tertiary evaluation, and 10% at other times, such as during surgery. The tertiary evaluation is where radiology fits into this pattern. They broke down missed injuries into patient factors, imaging factors, and image interpretation factors. In terms of patient factors, misleading or incomplete histories constitute 10% of missed or delayed diagnoses, such as this history from our hospital, which only says trauma. Clearly, this is not enough history. Patients with multiple severe injuries or serious and distracting injuries are more likely to have things missed. Additionally, patients with multiple injuries in the same extremity, particularly when there are bulky dressings or splints, patients with hemodynamic instability, and patients with decreased level of consciousness are more likely to have missed diagnoses. In terms of imaging factors, failure to obtain imaging of regions where there are signs or symptoms contributes to 15% of delayed diagnoses. Among patients with missed or delayed diagnoses, in which imaging of the correct region had been performed, 60% of errors were due to incomplete or poor quality. In terms of image interpretation factors, image misinterpretation constitutes 10 to 30% of delayed or misdiagnoses of injuries. Less misinterpretation occurs with greater experience, and there is a component of satisfaction of search. We will discuss the easily missed injuries of the spine, upper extremity, pelvis, and lower extremity. First, we'll start with the spine. In a study by Platzer, they analyzed 367 patients with cervical spine injuries who were admitted to their trauma unit. They found that lower cervical spine fractures were missed slightly greater than upper cervical spine fractures, and that the reason for diagnostic failures was most commonly misinterpretation. However, the combination of incomplete and inadequate radiographs was almost equally, if not more, important than misinterpretation. According to the ACR appropriateness criteria of 2009, they state that a CT cervical spine without contrast is the most important test that can be done in the patient with trauma and suspected cervical spine injury. This is more important than an X-ray. This is because multiple studies have shown that 15 to 30% of cervical spine fractures are missed on conventional radiographs. However, often radiographs are performed for screening purposes, and we will go through a basic approach to reading them. When you look at every cervical spine X-ray, it's very important to have an approach. You should look separately at the upper cervical spine, that is C1 and C2, from the lower cervical spine, that is C3 to C7, and you should look at the prevertebral soft tissues. In terms of the upper cervical spine, the normal predental space should be less than 3 millimeters in adults and less than 5 millimeters in children. Harris's ring, as seen on the image on the right, should always be complete. There are a number of fractures which classically disrupt Harris's ring that we'll go through. The spinolaminar line should always intersect the opistheon. In addition, the basion dental interval is the distance between the clivus, or tip of the basion, and the tip of the dens. This should be less than 12 millimeters. In addition, a line drawn along the posterior aspect of the C2 vertebral body, known as the posterior axial line, should be less than 12 millimeters posterior to, or less than 4 millimeters anterior to, the basion, or tip of the clivus, and this is termed the basion axial. In addition, the lateral masses of C1 and C2 should have less than 1 to 2 millimeters of malalignment. In addition, the atlantodental spaces should be symmetric. It is very important, when looking at the lower cervical spine, to assess smooth contours of the following 4 lines: the anterior vertebral body line, the posterior vertebral body line, the articular pillars, and the spinolaminar line. In addition, the disc and interspinous spaces should be uniform at each level. In terms of prevertebral soft tissues, the most important factor is a focal contour abnormality. It is said that at the level of C2, the prevertebral soft tissue should be less than or equal to 7 millimeters in thickness. At the level of C3, C4, it should be less than or equal to 5 millimeters in thickness, and at the level of C6, it should be less than or equal to 22 millimeters in adults and 14 millimeters in children. Please know that the absence of soft tissue swelling should not be a negative predictor of cervical spine injury. In addition, prevertebral soft tissues cannot be accurately evaluated in patients who have had traumatic endotracheal or nasogastric tube intubation. In terms of upper cervical spine injuries at C1 and C2, these are very, very dangerous. We need to pay very close attention to this area. And common fractures in this region include atlanto-occipital dislocation, Jefferson fracture, odontoid process fracture, and hangman. First of all, we'll talk about atlanto-occipital dislocation. The mechanism is severe flexion or extension of the upper cervical spine, usually high-speed motor vehicle accidents. Here, we see disruption of the stabilizing ligaments between C1 and the occiput. Death usually occurs immediately, so it's quite rare for us to see this in the emergency department. In this injury, you see anterior translation of the skull on the vertebral column. This is more common than posterior translation. You see widening of the basion dental interval and or basion axial interval, otherwise known as the BDI-BAI method. This has been shown to be more accurate than more historic methods, such as the Powers ratio, which you may have heard of. The major stabilizing ligaments connecting the occiput to C1 include the tectorial membrane, which is a continuation of the posterior longitudinal ligament. In addition, the alar ligaments and cruciform ligaments, as shown in this Netter diagram. On the left, we have a normal patient in which the basion axial interval is less than 12 millimeters and the basion dental interval is also less than 12 millimeters. This is a normal relationship. On the right, there is a widening of the basion dental interval greater than 12 millimeters. This is abnormal, and this patient has atlanto-occipital dislocation. Next, we'll talk about Jefferson fractures. The mechanism is axial loading. By definition, there are multiple fractures of the C1 arch in this injury. There is lateral displacement of the lateral masses of C1 in relation to C2 on the odontoid view. If this malalignment of the lateral masses is greater to or equal to 7 millimeters when you add them up on both sides, this indicates disruption of the transverse ligaments, and this is an unstable injury. On the diagram on the right, we can see the C1 vertebral body and the transverse ligaments. The treatment for this injury is conservative with external immobilization unless. We have a Netter diagram here on the right of the C1 vertebral body, and we can see the transverse ligaments which attach the C1 vertebral body with the odontoid process. If these are broken, this is an unstable. On the left, there is an odontoid view in which the lateral masses of C1 do not align with the lateral masses of C2. This is classic appearance for a Jefferson fracture. Note on the right that the lateral masses of C1 line up normally in relation to those of C2. Here we have a patient which demonstrates a break in the posterior elements of the C1 vertebral body in keeping with a Jefferson fracture. Also note that this patient had a subtle fracture of the odontoid process, which we'll discuss in more detail later. On the patient's CT scan, we see bilateral fractures of the posterior arch of C1 in keeping with the Jefferson fracture. Next, we'll talk about odontoid process fractures. The mechanism is hyperextension, hyperflexion, and/or rotation. Please know that in the setting of osteoporosis in elderly patients, they're more likely to have a type 2 fracture and non-union. A type 1 fracture is an avulsion at the tip of the insertion of the alar ligament. A type 2 fracture is a fracture at the base of the odontoid process, and a type 3 fracture is a fracture that extends into the body of the axis. The type 2 fracture is most likely to progress to non-union without surgical fusion. On the top left, there's a type 1 fracture. Note that this fracture is very, very difficult to visualize secondary to overlapping structure, and it's commonly missed. On the right, a type 2 fracture, we see a fracture of the base of the odontoid process, and on the bottom there's a type 3 fracture. The fracture extends into the body of C2. In a type 3 odontoid process fracture, there is classically disruption of Harris's ring. The type 1 fracture is treated by immobilization, the type 2 fracture by surgical fusion, and the type 3 fracture by traction and bracing. Next, we'll talk about Hangman's fracture. It is defined as bilateral fractures of the C2 pars interarticularis, as seen on the diagram on the right. The mechanism is hyperextension, and neurologic sequelae occur in a minority, only 25%, and this is because, in this fracture, the cervical canal is actually widened as opposed to narrowed. An atypical Hangman's fracture is a fracture that extends into the posterior cortex of the C2 vertebral body, and this is another fracture that demonstrates disruption of Harris's ring. This fracture is treated conservatively with immobilization unless it is. Here's a diagram of a patient that has a subtle fracture through the pars interarticularis of C2. Here's a different patient, CT, which again demonstrates a fracture through the pars interarticularis, how this fracture also extends into the body of C2, as we see on the CT scan here. This is an atypical Hangman's fracture. Next, we'll talk about a hyperflexion sprain. The clues are widened spinous processes, akyphotic deformity, and widening of the posterior aspect of the involved disc space can also be seen. In the literature, it states that greater than 11 degrees of kyphosis is considered a sign of instability. The treatment is immobilization, surgical fusion, or decompression if there's associated cord injury. This is a patient that came into our hospital that had a motor vehicle accident in February of 2011. No fractures were seen. In fact, it was a normal study except for the fact that there are some degenerative changes. Their CT scan also showed some degenerative changes, but no fractures. However, in March of 2011, there's a very subtle kyphosis now seen at C4-5. A month later, in April 2011, this kyphosis has increased at C4-5. And in May, it's increased even more. The patient had flexion and extension views at the time, which demonstrates instability, meaning an increased kyphosis and anterior translation of C4 on C5 on the flexion related to the extension views. This is classic for delayed instability with a hyperflexion sprain. So what is the role of flexion and extension views? They should never be performed in patients with unstable cervical spine fractures. This can make the fracture worse. In a study by INSCO, 30% of patients cannot adequately flex and extend their necks in the setting of acute injury, so this would limit the utility of flexion and extension views, and this is thought to be secondary to muscle spasm. In the setting of normal radiographs, flexion and extension views can be useful to assess for ligamentous instability. And instability is defined as greater than or equal to 3.5 millimeters of anteroposterior motion or greater than 20 degrees of angular motion between two adjacent vertebrae. Next, we'll talk about a Clay-Shevler's fracture. The mechanism is abrupt hyperflexion with lower cervical muscular contraction and forced transmission through the supraspinous ligaments. It is an avulsion fracture of the posterior spinous process. It is most common at the lower cervical or upper thoracic spine, specifically at C7 and T1. It is a stable injury and the treatment is conservative. On this radiograph, we see a displaced fracture of the C7 spinous process. On the CT scan, we see the same finding. There is a case report of a Wii-related Clay-Shevler's fracture. This patient reported that this injury had started immediately after swinging his Wii game console during a rather vigorous game. Next, we'll talk about flexion teardrop fractures. The mechanism is hyperflexion and compression. It is an oblique coronal fracture through the anterior-inferior vertebral body. The lower cervical vertebral body is most common. In this injury, you see kyphosis, fanning of the spinous processes, and distraction of the facet joints. It is a highly unstable injury and associated with severe spinal cord injury, specifically the anterior cord syndrome. The treatment is immobilization, surgical fusion, and spinal decompression if there is associated cord injury. On this radiograph, we can see a fracture of the anterior-inferior aspect of the lower cervical vertebral body with adjacent prevertebral soft tissue swelling. On the CT scan, we see the same finding. However, we also see a kyphosis at this level, indicating a flexion injury. And on the CT scan, we see widening of the associated facet joint. On the other hand, an extension teardrop fracture is seen in the setting of hyperextension with axial compression. It is an avulsion of the anterior-inferior bone fragment by the anterior longitudinal ligament. This is most common in the upper cervical spine, specifically at C2 and C3. You may see other signs of hyperextension injury. It can cause central cord syndrome. However, cord injury is less common than seen with a flexion teardrop fracture. The treatment is immobilization, surgical fusion, and again, decompression if there is associated spinal cord injury. This patient also had a CT scan, which demonstrates a bone fragment at the anterior-inferior aspect of the C2 vertebral body. This is a different patient with an extension teardrop fracture that demonstrates a small bone fragment at the anterior-inferior aspect of the C3 vertebral body, and the CT scan shows the same finding. On MRI, this patient also had a prevertebral hematoma at this level. So what is the difference between an extension and a flexion teardrop fracture? With an extension teardrop, there is rarely a neurological deficit, and when there is, it is central cord syndrome. However, with a flexion teardrop, there's often severe neurological deficit, specifically anterior cord syndrome. The imaging of an extension teardrop is a widened anterior disc, as seen with an extension injury, and it is most commonly at C2 and C3. However, with a flexion teardrop fracture, you see widened posterior elements, a kyphosis, and this is most common at C5 and C6. Next, we'll talk about thoracic and lumbar spine injuries. There is a very important theory termed the three-column model of Denis. The injury is unstable if two or more columns are involved. This is a diagram from the original paper by Denis, which defines the anterior column as the space between the anterior longitudinal ligament, the anterior half of the vertebral body, and the anterior annulus fibrosus. The middle column is defined as the posterior longitudinal ligament, the posterior vertebral body, and the posterior annulus fibrosus. The posterior column is defined by the posterior elements and the posterior ligamentous complex. It is very important to use the correct nomenclature for various fractures of the thoracic and lumbar spine because these have implications for treatment. A compression fracture is defined as a stress failure of the anterior column with an intact middle column. And in the original paper by Denis, the radiographic characteristics are defined as the lateral film showing a normal posterior body cortex and a normal height of the posterior vertebral body with an intact middle column. Note on the CT that there is a compression fracture of the superior end plate of this vertebral body, and note that the posterior aspect of the vertebral body is intact with no retropulsion of bone fragments into the canal. On the other hand, a burst fracture is defined as a fracture under compression of the anterior and middle columns. In the original paper, the radiographic characteristics are that the lateral radiograph shows a fracture of the posterior wall cortex with loss of height of the posterior vertebral body and retropulsion of a bone fragment into the canal. On this CT, we see a fracture of this vertebral body. However, the posterior cortex is also involved. In addition, there is a small bone fragment which is within the spinal canal. This is a burst fracture. A chance fracture is defined as failure of the posterior and middle columns under tension. Radiographically, the pathognomonic sign is the horizontal split of the transverse processes as well as the pedicles. On the CT, we see a horizontal split of the spinous process as well as the vertebral body. This is a chance fracture. Next, we'll speak about easily missed injuries of the upper extremity. AC joint injury is classically defined as 3 different grades. The original classification by Tossi is that a grade 1 injury is a sprain of the AC ligament without elevation of the clavicle. Most commonly, a grade 1 injury demonstrates normal radiographs. There may be a small amount of adjacent soft tissue swelling. In the literature, it is said that the normal AC joint distance is less than 6 to 7 millimeters, and the normal coracoclavicular distance is less than 11 to 13 millimeters. However, it is very controversial whether absolute numbers are actually useful for the degree of AC joint widening. The most useful thing is to compare the AC joint with the asymptomatic side to see if there is a difference, and greater than 2 millimeters of difference would be potentially abnormal, especially in the setting of symptoms. A grade 2 injury is defined as a tear of the AC ligament with an intact CC ligaments. And here, a radiograph of a grade 2 AC joint injury, we see that there's elevation of the distal clavicle in relation to the acromion, and we see preservation of the coracoclavicular distance of less than 11 to 13 millimeters. With a grade 3 injury, there is tear of both the AC ligament and CC ligaments, and here we see elevation of the distal clavicle in relation to the acromion, indicating a tear of the AC ligament. In addition, we have widening of the coracoclavicular distance, indicating a tear of the coracoclavicular ligaments. The treatment for AC joint injuries are conservative, unless in the setting of grade 3 injury in athletes they may perform surgical fixation. Next, we'll talk about sternoclavicular joint dislocation. This is a rare injury representing only 2 to 3% of dislocations about the shoulder. The mechanism is blunt trauma. Anterior dislocation is more common than posterior dislocation. Posterior clavicle dislocation is potentially life-threatening if there is injury to the great vessels, nerves, or trachea. And if suspected, a contrast-enhanced CT of the chest should be performed to exclude mediastinal injury. The treatment is closed reduction, and if this fails, then the patient will need to go on to surgical reduction. On the right, we have a chest X-ray, cone-down image, which demonstrates abnormal overlap of the medial aspect of the left clavicle in relation to the manubrium of the sternum. We note the normal relationship on the right. This should raise bells in our head, and we should suspect sternoclavicular joint dislocation and obtain a CT scan in this patient. This patient has posterior dislocation of the left clavicle in relation to the manubrium of the sternum, and we can see how easily mediastinal structures could be injured in this setting. Next, we'll speak about posterior shoulder dislocation. The mechanism is most commonly an epileptic seizure. However, a blow to a flexed, adducted, and internally rotated shoulder can also occur in posterior shoulder dislocation. Patients with a hypoplastic glenoid have increased risk. This is a rare injury representing 2 to 5% of all shoulder dislocations. It is said to be unrecognized on initial evaluation in more than 50% of cases. In this injury, the humeral head is held in persistent internal rotation and has a rounded morphology on AP radiographs termed the light bulb sign, as we can see here. In addition, in some cases, there may be loss of the normal overlap between the humeral head and glenoid. We don't see that in our case, but when seen, this is termed the rim sign. In addition, it's always important to look for a reverse Hill-Sachs fracture, and that is seen on a radiograph as a linear radiodense line paralleling the humeral head articular surface on the AP radiograph, as we can see here. In addition, we see an obvious impaction fracture of the superior aspect of the humeral head. It's very important to always look at the axillary transcapular views. Here, the axillary view demonstrates posterior dislocation of the humeral head in relation to the glenoid. We also have a large impaction fracture of the anterior aspect of the humeral head. And again, on this transcapular Y view, we have posterior dislocation of the humeral head in relation to the glenoid, and we can also again see the impaction fracture. Next, we'll talk about radial head and neck fractures. The mechanism is an impaction injury due to axial overloading of the lateral elbow during a fall on an outstretched hand. In this injury, a positive fat pad sign, indicating an elbow effusion, should definitely raise suspicion of a radial head or neck fracture in an adult. If an occult fracture is suspected, you can do either oblique radiographs, a CT scan or MRI, or even delayed radiographs in 10 to 14 days post-immobilization should be considered. In addition, if you ever see a comminuted radial head fracture, this should raise suspicion for an associated subluxation of the distal radial ulnar joint, and this is termed an Essex-Lopresti injury. In this patient, we see an elbow effusion, first of all. We see the posterior elbow fat pad, which should never be normally visualized unless there is the presence of an elbow effusion. In addition, we see elevation of the anterior fat pad in keeping with a Sale sign. These findings together are in keeping with an elbow effusion. In addition, there's a very, very subtle linear lucency projecting over the radial neck in keeping with a non-displaced radial neck fracture. In this case, there is a comminuted fracture of the radial head. This should raise suspicion of a dislocation of the distal radial ulnar joint, which we see in this case. This is termed an Essex-Lopresti injury. There is a classification for radial head and neck fractures. A type 1 fracture, there is displacement of less than 2 millimeters. A type 2 fracture, there is displacement of greater than 2 millimeters or segmental involving less than 30% of the radial head. These are treated conservatively. Type 3 and 4 fractures are treated with operative fixation, and if you do see comminution again of the radial head, think of an Essex-Lopresti injury and you have to image the. Next is the capitellum fracture. The mechanism of an anterior fracture is trauma with the elbow in flexion. The mechanism of a posterior fracture is trauma with the elbow in extension. This is a rare injury, accounting for 1% of all elbow fractures. A positive fat pad sign may be the only radiographic finding. Again, this indicates an elbow effusion. The capitellum is quite unique because it is held in place by very few soft tissue attachments, and if there is a fracture, the fracture fragment is far more likely to displace into the joint and cause symptoms for the patient such as locking of the joint. In this image on the right, we see elevation of the anterior fat pad, and we see the presence of the posterior olecranon fat pad. These are in keeping with an elbow effusion. There is a very, very subtle linear lucency projecting through the capitellum on this view. And again, a very subtle linear lucency indicating a non-displaced fracture of the capitellum. And the CT scan confirms an impaction fracture of the posterior capitellum should raise suspicion for a previous elbow dislocation. We can see here on the radiograph of the right, there is subtle flattening and irregularity of the posterior capitellum. The CT scan confirms this. This patient also had a comminuted fracture of the radial head and a bone fragment anteriorly. This patient had a previous elbow dislocation. The treatment of capitellum fractures are pin fixation if there are large fragments, and if they're small fragments, then the fragments are actually removed because they're symptomatic for the patient. Next, we'll move on to coronoid process fractures. The mechanism is either hyperextension of the elbow, with the coronoid process being avulsed by the brachialis muscle, or it can be fractured in the setting of a posterior elbow dislocation. These fractures occur in 2 to 15% of all elbow dislocations. They rarely occur in isolation, usually associated with other bone and soft tissue injuries. There is a terrible triad of elbow dislocation, coronoid process fractures, and radial head fractures. On this netter image, we see the insertion of the brachialis muscle, and we can imagine that if there is a sudden force of this muscle, there could be an avulsion of the coronoid process, which is located immediately proximal to it. In this patient, there is a fracture of the coronoid process in the setting of a posterior elbow dislocation. There is a classification for coronoid process fractures called the O'Driscoll classification. A type 1 is a fracture at the tip of the coronoid process. A type 2 is a fracture of the anteromedial facet, which we will speak about next. Additionally, there's a type 3, which is a fracture of the base. Concurrent dislocations or associated fractures, most commonly the radial head or olecranon, occurs in increasing frequency with each of the types of coronoid process fractures, respectively. The fracture of the anteromedial facet of the coronoid is specifically important because delayed treatment may result in varus and posteromedial instability with early onset osteoarthritis. In addition, this fracture requires a very specific treatment, and that is surgical fixation of the coronoid via a medial approach, even when the fracture is very small. When you see this fracture, it's very important that orthopedics gets involved in this case. Next, we'll talk about distal radius fractures. The mechanism is a fall on an outstretched hand. It is the most commonly missed fracture in the emergency department in the study by Petineau. This is most likely because it is a very common fracture. In addition, displacement of the pronator fat pad on lateral radiographs of the wrist has not been shown to be a good predictor of an occult distal radius fracture. On the right, there is a very subtle linear lucency projecting through the distal radius with a small amount of disruption of the lateral cortex. This patient also incidentally had a lipoma on the dorsal aspect of their hand, indicated by this scar. Next, we'll talk about scaphoid fractures. The mechanism is a fall on an outstretched hand, as we see in the diagram on the right. It is the most commonly fractured carpal bone and is missed in 30% of initial radiographs. In addition to a standard wrist radiograph, a PA view with the wrist in ulnar deviation, as seen in this image, can be performed. And this specific scaphoid view lengthens out the scaphoid, and it's easier for us to see a scaphoid fracture. It has been shown that displacement of the scaphoid fat pad has not been shown to be a good predictor of an occult scaphoid fracture. On this image on the right, there is a minimally displaced fracture of the scaphoid waist. 3 months later, the patient had 2 pins placed through the scaphoid. However, there is some subtle increased sclerosis of the proximal pole of the scaphoid, indicating early avascular necrosis. And 12 months later, the pins were removed, and we see even greater sclerosis of the proximal pole, indicating avascular necrosis. In addition, there is non-union of this fracture. We know that the blood supply of the scaphoid is distal to proximal, so the more proximal the fracture is, the more likely it is to develop avascular necrosis. Some of the complications of scaphoid fractures include delayed union or non-union, and we can see in this image on the top left there is corticated margins at the fracture line indicating either delayed union or non-union. In addition, you can see avascular necrosis. You can also see a dissi deformity with dorsal tilt of the lunate, and this is a sequelae of a scapholunate ligament injury. In addition, on the bottom you can see malunion, classically with a humpback deformity of the scaphoid. Next, we'll talk about a triquetrum fracture. The mechanism is an axial load on a dorsiflexed wrist. The dorsal portion of this bone is most commonly fractured. It is due to a avulsion of the dorsal intercarpal and radiotriquetral ligaments, as shown on the right. It is the second most commonly fractured carpal bone. It is seen on the lateral radiographs as a small bone fragment dorsal to the carpus, and treatment is immobilization. It is often occult on the PA view of the wrist. And here on the lateral view, we see the bone fragment dorsal to the carpus, indicating a triquetral fracture. Next, we'll speak about pisiform fractures. The mechanism is a direct blow during a fall on an outstretched hand. The pisiform is a sesamoid bone located within the flexocarpial ulnaris tendon. This is a very rare injury. It's best seen on the lateral radiograph, as noted on the right. It can be associated with ulnar nerve injury, and the treatment is immobilization. Next, we'll talk about the gamekeeper's thumb. The mechanism is hyperabduction of the thumb. It is an injury of the ulnar collateral ligament of the first MCP joint. It can be associated with an avulsion fracture at the ulnar aspect of the proximal phalanx of the thumb, where the ligament attaches. It can also be associated with a Stenner lesion, where the adductor aponeurosis is interposed between the ruptured ulnar collateral ligament and its distal attachment, presenting healing, as we see on the image on the right. The treatment for a gamekeeper's thumb is immobilization unless displaced ulnar collateral ligament injury occurs, including stentor lesion. In these settings, surgical fixation is required. Next, we'll talk about a Bennett fracture dislocation. The mechanism is an axial load on a partially flexed thumb, as occurs during a fist fight. It's an oblique intra-articular fracture of the base of the first metacarpal, where the lateral fragment is displaced dorsally and radially by the abductor pollicis longus tendon. We can see here the abductor pollicis longus tendon would displace the distal fragment radially. However, if this fracture is comminuted, it is termed a Rolando fracture. The treatment for a Bennett fracture is ORIF if there's greater than 20% articular surface involvement, and a Rolando fracture is best treated with closed reduction if it's highly comminuted, because these fractures just don't do well with fixation internally. Next, we'll talk about easily missed injuries of the pelvis. Sacral insufficiency fractures are commonly seen in the setting of osteoporosis, rheumatoid arthritis, corticosteroid medications, or radiation therapy. They're often not easily to see on radiographs secondary to overlapping bowel gas and decreased bone mineral density, which we see in this case on the right. It's very difficult to see the sacrum. They are often vertical and parallel the SI joints, and it's very important to look for any disruption of the sacral arcuate lines on the radiograph if possible. This patient went on to have a CT, and we do see that there are bilateral sacroiliac insufficiency fractures. On this radiograph in a different patient, we see very subtle disruption of an arcuate line on the left. This is a very important finding to look for on every radiograph of the pelvis. This same patient, we can see a fracture through the left sacral ala. Next, we'll speak about acetabular fractures. The mechanism is high-velocity trauma, usually during a motor vehicle accident. 20% of these fractures are associated with pelvic ring fractures, so it's important to keep looking for additional fractures. In acetabular fractures, a fracture or disruption of the iliopectineal line indicates a fracture of the anterior column, as shown in red on the image on the right. Disruption of the ilioischial line indicates a posterior column fracture, as indicated in purple on the diagram on the right. This patient has a very subtle left acetabular fracture. So, in order to characterize this fracture, we need to look at the iliopectineal line, the ilioischial line, the anterior acetabular wall, and the posterior acetabular wall. Note that the anterior acetabular wall always projects medial to the posterior acetabular wall. In this patient, we see subtle disruption of the ilioischial line, as here, and the ischial spine, indicating a posterior column fracture. The patient also has a fracture of the superior acetabular wall. It's very useful to look at Judet views for acetabular fractures. The external or iliac oblique view best shows the ilioischial line, indicating the posterior column, and the anterior wall, as indicated on the diagram. Note that in our patient we have a fracture extending through the ischial spine, indicating a posterior column fracture. Alternatively, an internal or obturator oblique view demonstrates best the iliopectineal line, which is the anterior column, and the posterior acetabular wall. In our patient, the iliopectineal line is intact, however there is subtle disruption of the posterior acetabular wall, indicating that this patient has a fracture combination of the posterior column and posterior. This patient had a CT scan which demonstrates a comminuted fracture of the posterior acetabular wall, as well as disruption of the ilioischial line, indicating a posterior column fracture, and again a sagittal image demonstrating a comminuted fracture of the posterior. Next, we'll talk about easily missed injuries of the lower extremity. Proximal femur insufficiency fractures are very difficult to see many times, secondary to decreased bone mineral density. In a study by Dominguez, 4.4% of patients with symptoms suspicious for hip fracture had fractures detected on MRI that were actually occult on radiographs. So, if a radiographically occult fracture is suspected, MRI or CT should be performed. And the treatment is internal fixation operatively, and that's of course assuming the patient is a surgical candidate. In this image of a T1 weighted MRI, there is a much more obvious finding, which is a hypointense line through the intertrochanteric region of the femur that was very, very subtle on the radiograph, indicating a non-displaced fracture. Next, we'll move on to proximal femur fatigue fractures. These are more common in runners, females greater than males. They classically occur at the medial femoral neck. You see a linear region of sclerosis perpendicular to the trabeculae with smooth associated periosteal reaction. If you see this, the treatment is to protect the patient from weight bearing, or it may actually progress to a complete fracture. On the MRI, it is more obvious. Within the right medial femoral neck, we see smooth periosteal reaction, as well as a linear region of sclerosis. On the fluid-sensitive MRI, we see adjacent bone marrow edema. Next, we'll move on to fractures that have a very high specificity for ACL injury. If you see any of the following fractures on a radiograph, an MRI should be performed to exclude internal derangement of the knee. A Sagan fracture is a fracture of the lateral aspect of the proximal tibia at the insertion of the mid-third of the lateral capsular ligament. A fracture at the anterior and medial aspect of the tibial eminence is also specific for an avulsion of the tibial insertion of the ACL. An arcuate fracture is a horizontally oriented fracture of the fibular styloid process at the attachment site of the arcuate ligament complex. If you see this, it is highly associated with injuries of the ACL, PCL, posterolateral joint capsule, popliteus muscle, and menisci. It is very important to obtain an MRI in this setting. An impaction fracture of the lateral femoral sulcus terminalis can also be seen. Suspect this when the depth of the lateral sulcus terminalis is greater than 2 millimeters. Next, we'll move on to lateral process of talus fractures. The mechanism is foot dorsiflexion and inversion, as occurs during snowboarding. Numerous ligaments originate at this site. There is a classification system. However, it is more important just to recognize the fracture than to specifically classify it, as orthopedics can then classify it and decide how they'd like to treat it. It's very important to recognize because delayed diagnosis often requires surgery. It can be very subtle, so it's important to look at this lateral process of the talus in every single ankle radiograph you see. Next, we'll move on to a fracture of the anterior process of the calcaneus. This is a rare injury, accounting for 3% of calcaneus fractures. The mechanism is sudden inversion on a plantar flexed foot, as seen in patients wearing high-heeled shoes. It is the attachment site of the bifurcate ligament, which we'll see next, and correct treatment requires immobilization for 4 weeks. So again, this can be very subtle, but it's very important to look at the anterior process of the calcaneus in every ankle and foot x-ray that you see. So here's the bifurcate ligament on this Netter diagram, which is a Y-shaped ligament which connects the anterior process of the calcaneus both to the navicular and the cuboid bones. Next, we'll speak about Lisfranc's fracture dislocation. It is an injury to the tarsometatarsal joint ligaments, particularly the Lisfranc ligament. The Lisfranc ligament attaches the medial aspect of the second metatarsal base to the medial cuneiform. You see associated lateral displacement of the second through fifth metatarsals, with possible fractures at the bases of the metatarsals. It is very, very important to pay very special attention to any malalignment of the medial margin of the second metatarsal versus the medial margin of the middle cuneiform. These should line up perfectly. In this case, they do not. In addition, you can do weight-bearing views, and in this patient, we see increased lateral displacement of the second metatarsal base in relation to the middle cuneiform, compared with a non-weight-bearing view. So if you are suspicious for this type of injury, it's easy to perform a weight-bearing view and see if there's any associated instability. In addition, on the lateral view, classically you can see dorsal displacement of the metatarsals in relation to the cuneiform. And lastly, we'll talk about fractures of the base of the fifth metatarsal. Lawrence and Bott devised a classification system which is commonly used. Type 1 is an avulsion fracture at the base of the fifth metatarsal. Type 2 is slightly more distal, known as a Jones fracture. And type 3 is a proximal diaphyseal stress fracture, as seen in blue. The mechanism is running or dancing, usually repetitive injury. The treatment can be ORIF, especially if in the setting of an athletic patient. The rate of non-union is 50% with non-operative treatment. In conclusion, musculoskeletal injuries are among the most commonly missed entities in the emergency department and in the setting of polytrauma. Contributing factors include lack of experience, satisfaction of search, incomplete or poor quality imaging, poor histories, and the setting of multiple injuries. The presence of a joint effusion or soft tissue swelling are very important clues. Knowledge of the common pitfalls and having an organized approach will prevent many of the commonly missed injuries.